Good morning, everyone. We are back together again here Tuesday morning for our now, I believe, 11th COVID-19 Innovations webinar. And it's great to be with everyone again today. Once again, I'm Gary Thompson, Medical Director for Quality, and I will be your host once again. Today we have Dr. Patel back with us. She's our pulmonary critical care lead for our COVID team in the medical ICU. So it's great to have her back. She will be discussing how the ICU has sort of incorporated non-ICU providers into their surge plan. Before we get to Dr. Patel, however, I'd like to take a couple of minutes just to give you a little update on some of the statistics that we're seeing countywide. I think there's some positive news and trends that are happening today. If you do look at the public health website, we have 1,751 confirmed cases. Unfortunately, we have had 50 deaths thus far, and we have 297 recoveries. The good news, despite a slight uptrend in the numbers, is the fact that our doubling time in the county has improved significantly. As of last week, as you recall, our doubling time was 4.6 days. Now, after some discussion yesterday, we're up to 7 to 8 days, which is a very positive sign. And specifically in the ICU, the doubling time countywide is about 10.5 days. And I think that's something that we are seeing in the intensive care units, on the front lines. So I think definitely we're in a positive trend with flattening the curve. I know the leadership at the EOC and public health are working on a revised model from what they previously had discussed. If we looked at the original model, today on the 14th, we would have run out of ICU beds by today. Fortunately, we are not seeing that at this point, so that's really, really great news. So on that note, despite our improvements, we still want to share some of the innovations that we've been able to put together with respect to surge planning. And if the topic at hand today is not applicable to our COVID crisis, given our improvement, well, perhaps this can be applied to the next disaster. God willing, it doesn't come, but we always want to be prepared, and this is a nice opportunity for us to collaborate together within our hospitals and be prepared for that next time. So, Dr. Patel, thank you very much for being with us this morning. Appreciate your participation once again. So I'm going to go ahead and hand it off to you to give us a review of the work that you've done. Then we'll sort of do a little bit of live chat here and perhaps entertain some questions along the way. So welcome back.
Hi, thanks for having me again. So it's so great to hear that the doubling time has slowed down, and I think we've definitely been seeing that in our ICU. Over the weekend, we held a pretty steady number of COVID patients, somewhere around 6 to 7. And I know that the projection was by Monday, our ICU was going to be full. So I'm so happy to see that we are slowing down the curve appropriately. But I was tasked with making a surge plan with a few other people in our COVID task force to stretch our ICU out to approximately 215 beds in case, what we were seeing in New York happening was going to happen here. We needed to have this flex plan to essentially almost convert the entire hospital into an ICU. With that, of course, given that there's only 5 pulmonary critical care, we do have 7 surgical critical care that we were going to lean on, but even that was not going to be enough to cover that complement of patients. So I created this cheat sheet. Let me share my screen here. There we go. Can you see that?
Yes, perfectly.
Yes. Okay. So I created a cheat sheet for treatment guidelines for the critical COVID-19 patient, essentially for the non-intensivist. On the left of the screen, I went over some brief lab symptoms, things that I think everyone at this point is pretty well aware of, except for maybe this bottom portion, the severe disease, the D-dimer greater than 1,000, CRP, oh, that's supposed to say 10, not 100. I'll correct that. LDH greater than 245, troponin, absolute lymph count less than 0.8, and a ferritin greater than 300. The other things that we are looking at is also an ESR, and from our rheumatology colleagues, we've learned that an elevated ESR that's starting to drop is actually an indication of worsening cytokine release syndrome and a poor prognostic sign, not a good sign. Labs that we'd like to do every few days is ferritin, ESR, CRP, LDH, D-dimer, of course, a daily CBC and a CMP to know what the state of everything else is. And then we always ask for a one-time hepatitis panel, HIV, flu, BNP, troponin, respiratory viral panel, although, again, in the last day or so, that is being pulled off, an X-ray and an EKG. We're asking for CT chest to be used very judiciously given the time to turn over the CT scan. It's been delaying other treatments for other patients. And if the CT chest is not going to make a difference in the current treatment, AKA we already think they have COVID and we are just waiting for the confirmatory test to come back, we're trying to avoid routine use of CT scans. So as I go over this document, I just want to remind everyone that this is a very dynamic living document. The things that were out there when I made this in the last day or two or three have been changing now that the IDSA has put out their guidelines. So while we have put this out and I've PDF'd it, you know, I clearly have to go back and change it every day or so as new information is coming out. You know, a couple days ago, that autopsy report from New Orleans came out, and that showed that maybe we should be hedging more towards therapeutic anticoagulation. And you know, IDSA put out their guidelines that they think steroids is beneficial for COVID plus ARDS, which was different before when everyone was kind of recommending against it. And again, many hospitals are putting out their guidelines. I know Mass General is disagreeing with IDSA, but you know, Kaiser Permanente and some of the larger systems in Michigan and Washington are recommending steroids. So I don't know that there's a lot of hard lines in this document, except for I think some of the vent-driven things, because that is a tried and true always. I think the rest of the things are a little bit in flex. So moving to the middle column, the respiratory failure, again, one of the things that's in flex is that top line right under respiratory failure, consider early intubation. We have actually seen great success with the awake proning, and we've been bringing patients over that are on high levels of oxygen, but doing well when they prone. And so we have actually been avoiding intubation. That has worked for 2 patients that we've been able to prone, step out of the ICU. One of the 2 is already home now. One is still in the hospital. But in this phase of where we were thinking early intubation, that patient would have been intubated and likely still been in the vent, on the vent in the ICU for days. Because when we are seeing people recover, we're seeing that they take sometimes 17 to 25 days on a vent. So I think, again, that's some of the things that are changing on this, but I want to really encourage the early awake intubation. We're doing that on all of our COVID wards, and it's really making a difference, I think. And it's keeping, I think, a large part of why our ICU numbers are down. Okay, the next thing we're doing is avoid BiPAP and nebulizer and high flow nasal cannula greater than 30 liters. Another thing that has changed in our ICU rooms and the 2500 ward, which is a COVID ward, all of the rooms have been converted to a negative pressure. So in those rooms, we are allowing nebulizers and high flow nasal cannula greater than 30 liters with the with the expectation that whoever's starting the nebulizer, despite having adequate PPE, still step out of the room for the majority of the time of nebulizing and maybe for a few minutes afterwards, just to minimize any potential aerosolization that's there. BiPAP, we have talked about using in an ICU since the doors are glass and we can see right through. I would generally try to avoid BiPAP in a room where you cannot be in there watching the patient, because if they vomit, the risk of aspiration is still astronomically high, and we wouldn't want that. So again, some of these things are changing as we've been able to convert our rooms to negative pressure. And then lastly, watching for increasing FiO2 is always going to be a tried and true statement that we will stand by. So when these patients are getting ventilated, we're putting them on lung protective ventilation. We have printed out a tidal volume chart for ideal body weight and put them on all of the vents so that if any non-intensivist is taking care of the patient to determine a tidal volume, all they have to do is look at the picture or the chart on the side of the bed. The important thing to note on these tidal volumes, it's 6 cc's per kg of ideal body weight. What I tell my residents is I'm 5'2", and this is the size of my thoracic cavity. If I gained 100 pounds, my thoracic cavity isn't getting any bigger. My lungs aren't getting larger. So it's important to remember to base that tidal volume off the ideal body weight, which is to give an estimate of their lung size and thoracic cavity. We want to look at plateau pressures, which is kind of the evening pressures of less than 30, a driving pressure of less than 15, which is our plateau minus our PEEP. And we're looking really just for an O2 sat of 92 to 96%. We're not trying to drive for the 100. There has been questionable data whether, this 96 to 100% is actually harmful given the free or the reactive oxygen species that we see, the free radicals. Other things, and permissive hypercapnia to a pH of greater than 7.15, but that's only if we have to. If we can keep them at a pH of 7.31 or 7.28, that is better than if we keep them at 7.15. But if the best we can do is 7.15, then we will tolerate 7.15. It's kind of our lower limit of where we aim to, not our actual goal. We want to start with a PEEP of 10 and an FiO2 that's very high, and ideally start doing the step ladder where we march up our PEEP and down our FiO2 as the patient tolerates for our goal of 92 to 96%. And to compensate for the lower tidal volume that we have to stick up top, we have to do a higher respiratory rate. So I generally start closer to 18. A lot of these patients, even when you stick them on a respiratory rate of 18, are going to be driving on their own to a respiratory rate of 28, 26. And so depending on how they're doing fighting the vent, we either want to let them permissively drive or just really sedate them heavily and take over and have the vent do all of the breathing for them. We're still driving on this conservative fluid strategy. We don't want maintenance fluid on any of these patients that are ventilated, and the diuresis is tolerated. My goal is really to keep them euvolemic to maybe slightly positive. Again, that's something different that has come out than our general ARDS patient. Our ARDS patient, normally we really want to dry out as much as possible. But given this risk of viscosity and possible microthrombi that we're seeing as part of the damage to the kidneys, I think our goal for these patients is shifting to just euvolemia instead of hypovolemia. Sedation is again dependent on our spectrum. We want a RASS of -1, which is where you can, say their name and they're open their eyes to you, to -3, which is where they're very deep sedation. The more the vent is working for them, the more we are relying on the vent to do the work, the deeper the sedation I expect them to have. If they are on minimal vent settings, then I would like to keep them minimally sedated so that we can really wake them up aggressively and see how they're doing in the attempts to do a spontaneous breathing trial, an awakening trial, and get them extubated. But as they get sicker, when they are more awake, they start to fight the vent and it starts to break off breaths that are being delivered, and it starts to increase their peak pressures, and they start to desaturate and become more hypoxic. So on those patients, we want them heavily sedated. It says here our first line is propofol, then dexmedetomidine or Precedex, and then midazolam or ketamine. Again, when this document was created, we were not in a drug shortage. So now all of these drugs are in flex. Propofol, we're on a shortage. We're trying to avoid it. Precedex, still on a shortage. We're really driving with midazolam, and we've added ketamine as one of our main drivers. I'm hoping we get Propofol back. It is, my favorite with Precedex as far as a sedative because of its easy on, easy off mechanism. But unfortunately, given the severity of the drug shortages, we're having to be very creative. You'll see that over here with the analgesia as well. Our CPOT is less than 2. Our recommendation is fentanyl pushes or a fentanyl drip, but we are actually running low on fentanyl drips as well. So we have replaced our fentanyl pushes and drip as first line with oxycodone PO for analgesia. And if that doesn't work, we have this step-up method. The pharmacists have gotten together with 2 of the other intensivists and come up with an algorithm of sorts for analgesia and sedation for what our options are currently and what we can now think of as first line, second line, third line to reach our goals. I think I was on a county-wide call with Dr. Taboinka the other day with a bunch of the hospital executive suite people who I think we had discussed it, and that document was going to be shared forward. So I think that should hopefully be making its way out to the 17 hospitals in the county as well, because it was incredibly useful when I saw the document, and now I have it taped all over our workroom and in my office so that I know where our new algorithm of treatment is going to be. The other things that we consider for these severely respiratory failure patients is paralytics if they're desynchronous. We do try to avoid that if we can. We know that it contributes to ICU myopathy and polyneuropathy, which is just making the recovery more difficult. But again, if we need to, we will. We'll always start with a push to make sure that it is working and going to improve our mechanics before I put them on a drip. And again, our drips are also on shortage, so we're going to have to start becoming more creative with how we do these things. And then the other thing that we have already discussed, I think earlier in the week, there was a webinar on it. And today I mentioned earlier the proning. So the awake proning has really done wonders. We've seen a lot of great success of the avoiding intubations. And then in our intubated patients, we're proning. We normally rely on the rotoprone bed, which is that massive contraption where they're just packed in, and it automatically rolls them. Well, there's obviously also a shortage of the rotoprone bed, so we have instituted manual proning with a team of OR techs, I believe, and our nurses, respiratory therapists, and of course we are bedside as well, to prone these patients for at least 16 hours in the day. I think Kim and Dr. Thapamagar had talked on that earlier, so I'm not going to go heavily into it, but our recommendation is proning any patient with a P to F of less than 150. I think we are liberalizing that number also to proning anyone that is requiring any tiny amount of oxygen on the ward while awake. And then I'm starting to prone once their P to F is less than 200 in the ICU, just because by the time they're 200, the next time we check, they will be at 150. And so it just lets us kind of move faster and not figure these things out towards the end of the day. The last column over here on the right is the hemodynamics. We have our vasopressor order. Of course, we love Levophed, norepinephrine first. Then we're adding vasopressin fixed at 0.04 and then epinephrine. I think given the possible cardiac dysfunction, we are trying to shy away from phenylephrine or neosynephrine. If we have to add it, we will, but this is our 1, 2, and 3. Again, with the drug shortages, we know that Levophed is on a shortage, so right now we are still using it, but I'm sure at some point our epinephrine will be our first driver with vaso a second. Our goal map is still 60 to 65. We've been throwing on dobutamine if there is heart failure concurrently, so dobutamine and Levophed together is completely appropriate. And this is our old classic treatment, and my kind of threshold to start stress dose steroids is 200 milligrams a day if they are on more than 2 pressors or more. We've been asking our pharmacy to actually write an order where we do 200 milligrams IV over 24 hours, and this is better than the 50 IVQ6 that we used to do, because this avoids these spikes in blood glucose. It's just a continuous 24-hour drip of hydrocortisone. And our driving IV fluids for anything is lactated ringers, then NS, and then albumin. We know albumin doesn't really have any improved outcomes. It's increased cost with no real benefit. So we really are driving with lactated ringers, which is more isotonic to the patient. Oops, did that pop up the wrong thing here? Okay. Other therapeutics, we are starting empirically with broad spectrum antibiotics to cover. We had been doing, ceftriaxone and azithromycin for community-acquired pneumonia. I think given the QT prolongation and a lot of these people still getting started on Plaquenil, we're starting to switch our azithromycin to doxycycline instead. And that has just happened in the last day or so. Our glucose is the same as normal, a goal of 140 to 180. We are doing heparin or Lovenox prophylaxis, and this says no routine steroids. Again, with these patients with severe ARDS and COVID positive, the Society of Critical Care Medicine and the Infectious Disease Society of America have put out that they both are very supportive of doing steroids for these patients. So we have shifted, and again, that's controversial. I know that some large institutions that are well respected are not doing it. Some large institutions that are well respected are doing it. I think we have come down on the line to try doing it. I think from those other institutions, as well as some anecdotal evidence from some other intensivists around the country that I had worked with previously, that they have been seeing good success with it. So we're going to try it. This heparin or Lovenox prophylaxis, unless contraindicated, we've taken that even further with the recent information. There's the abstract that came out that said, therapeutic anticoagulation for anyone that had a D-dimer greater than 6 times your upper limit of normal. Those patients had a better, lower mortality than the patients who weren't treated with therapeutic anticoagulation. This, along with all of these autopsy reports that are showing that there is microthrombi in the vessels of the lungs that may be a large part of the AA gradient and the hypoxia we're seeing, we have shifted a lot towards therapeutic anticoagulation, or at least mid-dose fixed heparin for the patients that aren't meeting that 6 times upper limit of normal. That controversy is there. My group and I were talking about it. There is the 6 times upper limit of normal number that was in the abstract, but there are other information out there that's saying just a D-dimer greater than 1200 is where we should be doing therapeutic anticoagulation. Our lab's threshold for our upper limit of normal is greater than 0.55. So 1200 doesn't meet the 6 times. So 550, 1200 is not meeting that greater than 6 times upper limit of normal. So I think we are still a mixed bag within the 5 of us of what we want to do, but we are leaning more towards aggressive anticoagulation with a therapeutic regimen as opposed to just prophylaxis or no heparin or Lovenox. I'm mostly doing heparin just because it's an easy on, easy off, anti-tradable. We have been seeing a few of our patients come up with GI bleeds, kind of spontaneously from the stress, maybe ulcers. So I think the heparin is the better choice over the Lovenox just because we do have the ability to turn it off rapidly if things are going on. And then troubleshooting, this was just a quick cheat sheet in the corner. If there is a low PO2 on your ABG, what can you do? Increase the PEEP and the FiO2. We know the PEEP recruits the alveoli or prevents de-recruitment of the alveoli, but that effect is not going to take place in the next breath. So we want to bump up the FiO2 to support them while we have that improvement from the PEEP and then rapidly try to titrate down the FiO2. I tell my residents that the FiO2, you bring it up and then you want to try to bring it down as fast as possible because that's really your plan B. When the patient has a bowel movement and they roll them to clean them up and they desaturate then, if you're already on 100% FiO2, you have nothing left to give the patient. And so the goal is always to bring the FiO2 down as low as possible while using your PEEP to balance that out. And the FiO2, again, it's your Hail Mary when something is going on. It buys you a little bit of time to figure out what is going on. Next, a high CO2, you want to increase the respiratory rate or the tidal volume, anything to increase our minute ventilation, which is how much air is blowing through the lungs in a minute to remove waste, which our lung waste is CO2. These things to look at your tidal volume or your respiratory rate, there are a few things that we have to look at. Number one, what are the peak and plateau pressures? Do we have room to go up on the tidal volume? If we don't, and we're going up on the respiratory rate, what's the rate the patient is driving at? If you're setting them at 22 and they're driving at 28, you taking the respiratory rate up to 25 isn't actually going to make that difference. And taking the patient to 30 may not allow them to exhale completely, thus increasing your CO2. So I think these are some easy kind of troubleshooting tips, but please don't hesitate to call for help. The respiratory therapists are incredibly skilled at knowing these things. And of course, the pulmonologists are always happy to help out. And then high peak pressures or plateau pressures. This is causing barotrauma to the lungs or volutrauma. We want to prevent that because that's really putting our patients at risk for pneumothorax. So what we can do there is, again, decrease our tidal volume or increase our respiratory rate with a decrease in the tidal volume to compensate. And then high peak pressures with a normal plateau pressure. If there's a big difference in your peaks and plateaus, we think that there's probably something in the airways or the tubing, not the actual lungs themselves. So bronchospasm, and I think we've been seeing a lot of bronchospasm. A lot of these awake prone patients have been coughing very heavily, and we've been very liberal with our use of Advair and albuterol. And I think that's really calmed down the cough. So bronchospasm, and we know that viral illnesses cause reactive airways disease, not uncommonly. So I think really trying some Advair and albuterol will help. Mucus plugging we're seeing a lot of, and obstruction in the tubing. So the ET tube is kinked, or the patient is biting the ET tube, or there is a kink in the tubing that even makes its way to the ET tube, is where you'll generally see that very high differentiation between the high peak pressures and normal plateau pressures. So I know that was a lot. I just talked for about 20 minutes straight about our entire strategy. I'm happy to answer any questions, but I hope that the cheat sheet in and of itself is fairly straightforward and easy to read. Of course, this is not going to ride you through alone. You may need to rely on some help from the intensivists and the respiratory therapists and stuff, but I think it's a good starting off point to get people who are unfamiliar with these patients some basics to lean on.
Yeah, Dr. Patel, this was a fantastic presentation, very evidence-based, and I know there are some controversial issues within that with steroids and anticoagulation, but you really did a phenomenal job presenting the information. Maybe we can ask Christine to help distribute this cheat sheet, if you will, once you update it and revise it. And then I would also ask, as you spoke about the pharmacist medication algorithm that you found so valuable. So maybe we can distribute that out to the participants as well. You mentioned some comments about the cytokine release syndrome. And I know there have been a couple of patients that we have had our rheumatology specialists come in and address that issue. Can you tell us your experience with that thus far? And have you seen any anecdotal response to some of those therapies?
We've had our rheumatologists and our infectious disease specialists. It's kind of been a little team of three, the intensivists on the teams, plus those two working very closely together, because by the time they make it to the ICU, the assumption is that all of them are having the cytokine release storm or syndrome. We have given tocilizumab on, I believe it was 4 patients by this weekend, 4 of 6. I haven't seen any improvement. I'm not quite sure how rapidly I'm supposed to be seeing improvement. I started the steroids this weekend. I haven't seen any improvement from that. I'm hopeful that one of these things, both of these things together will help. The steroid dosing that we're using for the cytokine release storm patients, that SCCM and IDSA are endorsing. They endorse, but they don't give a dose. So I've heard that the dosage is anywhere from 1 mg per kg of solumedrol versus up to a gram, like a loading dose. With our rheumatologists, we settled on 60Q8 that will cover your 1 mg per kg, maybe a little bit extra, but it's an easy rounded number that is consistent across the board that we give for other diseases. So we pick that as our dose for steroids for the ARDS patients. I know that we have gotten rheumatology involved on the wards as well for the patients that are on higher amounts of oxygen that don't quite qualify them for the ICU. And I know that Dr. Sandhu has been driving our process here at Riverside University Health Systems. And I know that she has considered starting And I think has started it on a few patients out on the wards that are on, high flow 30 liters, 40%, 50%, things like that, to see if we can maybe use that as the panacea to avoid them making their way to the ICU. If earlier may be better.
Got it. Yeah, our, Dr. Sandhu and the rheumatology team have done a fantastic job collaborating with the intensivists, and I can't commend them more for their assistance. I know they're monitoring these labs on a daily basis, looking for trends and looking for that ultimate trigger to consider therapy. So they've done a fantastic job.
Yeah.
I do want to remind folks in the chat box, we have posted some of the previous video YouTube links, some of which are applicable to the discussion that we've had here. And Dr. Kumar has also posted our trend lines as far as testing. I believe this is county-wide, so please have a look at that as well. Are there any questions out there, either via the chat box or go ahead and unmute your microphone and be happy to entertain that. Okay. Well, we're a little bit over our 30-minute target here. I think this was an extremely valuable discussion. Dr. Patel, thank you very much for your contributions here, and I hope that all the folks participating felt like it was a beneficial discussion. I want to thank everybody again for being with us this morning, and we'll go ahead and close this webinar. We look forward to seeing you again tomorrow. So again, everybody, please stay safe and all the best to you.